different. I just started the recording, by the way. So this is Winter 2019 Pechakuchas. This is a very different, this is your kind of one opportunity to not be data. Like you're going to say a lot of data, but you can just have a little bit of fun with this. So it's enjoy it. Enjoy while you can. So I sent you all my little letter. Let me just pull it up. Does anybody have any questions about what we're doing or what our agenda is today? Yes, no, maybe? No. You guys really are asleep. All right. So what I would like to do is each one of you go. We'll time them. I would like, as always, each person to keep some notes on. I always like to look at the positives. So what someone else did that was real, like you really liked the way they presented it, or it was clear, or it was visually eye-catching, or it engaged you. All of the things that we've been working on with our teams for the whole term. So is there anyone, as I get my watch ready, you can all pull yours up on your screen so that you're ready. But is there anybody who would like to go first?
I'll go first.
Who is that? Steph? All right.
Yeah.
Steph, a brave soul. Let me get my
notes. This over with. Okay.
Hold on. Let me grab. You get ready. I'm going to get my notes ready. Okay, and I'm going to keep time, but I'd like another timekeeper as well. So can we just go down the row? Whitney, you are next to be, you're next to her, so I'm going to have you be timekeeper with me. Would that be okay? All right, so this is Stephanie. And Stephanie, as usual, whenever you feel like you're ready, you go ahead and just lead us off with, don't ever forget to introduce yourself.
Hello, my name is Stephanie Grauman, and my project is improving patient-centered sexual and reproductive health care in adolescents utilizing the guidelines for adolescent preventive services. The reason this project was implemented is due to the growing disparities in sexual health outcomes for our minority students. There has also been and continues to be a steady increase in the incidence rate of STIs in our district's high schools. The aim of this project was to increase the percentage of completed health risk screens and corresponding right care by 50% within 90 days. I'm happy to report that this goal was met with a 57% increase in completed screening and right care provision. Several predictions were made during this project. It was predicted that a standardized approach to screening for health risk behaviors, namely sexual risk behaviors, would increase identification of students, which in turn would increase the number of students receiving right care. It was also predicted that patient engagement tools such as a decision aid and option grid would increase students' sense of empowerment and enablement. Finally, it was predicted that regular QI meetings would increase team engagement, which would in turn increase student referrals for screening and right care. There were several small tests of change implemented throughout the project that led to the sustainment of a high level of team engagement, an increase in student empowerment, and optimization of the screening process and right care provision. This is my team that consists of health office staff, as well as school psychologists and social workers. Tests of change for team engagement included bi-weekly QI meetings where warm handouts were discussed and instituted, where a simulation of education and counseling occurred, and of course, where a lot of food was eaten. The GAPS health screen was given to students as they presented for care in the health office. This screen went through several alterations to simplify language and become more inclusive. Students were very agreeable to completing this form. In total, 183 students were screened, and only a handful of students declined to complete the screen. Patient engagement was promoted by utilizing an STI decision aid and later a contraception option grid, as well as a patient-centered contraception counseling curriculum from Planned Parenthood was added. Patient engagement was further enhanced by providing models of different contraception and digitalizing the decision aid and option grid. Students who indicated they were sexually active or seriously considering becoming sexually active were asked if they would like to receive right care. This care consisted of further screening, education and counseling, and as needed referral to treatment. In total, 96 students participated in the individual right care sessions, and again, only a handful of students declined to participate. The right care was tracked on a case management log. This log went through some minor changes, such as the addition of triage information so I could locate students at a later date to provide right care. And the right care components were also expanded as the needs of students were further ascertained. This is my team engagement run chart. As you can see, after the second QI meeting, engagement reached 100% and remained there for the duration of the project. This high level of engagement was due to team goal setting and relating members' professional goals to project objectives. This is the percentage of positive screens for sexual activity. As you can see, there was variability from day to day, but the median percentage of students indicating sexual activity was 45%, which is in alignment with the national average of 44%. This indicates that I did capture a representative population. This is my favorite run chart as it exhibits the large increase in student empowerment and enablement. I believe critical to this increase was addressing adolescent confidentiality and sexual health care rights with students, both verbally and in writing. The percentage of students reporting an increased sense of empowerment rose to a median of 88% by the end of the project. The completion of right care also had variability from day to day, but had an overall increase of 59%. The right care that wasn't received was due to time constraints and being unable to meet with all the students that had a positive screen. This issue will have to be examined further and addressed. The most important thing I learned is that adolescents can be engaged in preventive care and want to learn how to improve their sexual health. All it takes is a safe space that is easily accessible and staffed by open, non-judgmental providers. It also became evident that screening and right care isn't static and it can be altered depending on the situation and the student. During this project, there was an impact on the entire culture of the health office. Prior to implementation of this project, visits were problem-based, but now the focus has expanded to preventive services. I plan on continuing these services and hopefully expanding them into other environments. This project is generalizable and can be spread to the other high schools as sexual health services become a priority in the district. The sexual health screening and right care from this project will most likely be implemented with our condom availability program that will be piloted at West High School next fall. The experiences and knowledge I gained from this project will aid me in successful implementation of this program. In conclusion, this project was successful and I plan on working hard to sustain it both locally and system-wide. The district administration is impressed by the results and plan on using them to justify funding for additional healthcare services and programs. As I reflect on this project, I realize that I have gained valuable skills to make the changes I want to see. I now understand that improvement can start with local systems and spread to the local system and spread to other systems. I also discovered the importance of engaging stakeholders and team members in order for an improvement to come to fruition. My practice has been reinvigorated and I feel the sky is the limit. I'm done. Okay.
Dr. Butler, you're muted.
Hello?
Dr. Butler, you're muted.
Okay.
I'm looking at yours like, is she muted? Did you stay within time?
Yes, she was 6 minutes, 7 seconds.
Great. Okay. I'd like to get through everybody's first, if that's okay with you. Does anybody have an objection with doing it that way? Get you all so you're not so nervous and then we can talk? Okay. Who would like to go next?
I can go next.
All right, Jewel, you're up. And let's see, next to you is Nicole. Nicole, can you help be timekeeper? Thank you. So Julie, I'm going to mute myself whenever you're ready.
Okay.
Nice job, Stephanie.
Hi, I'm Julie Percival. Welcome to my presentation of our Quality Improvement Project, Improving Mammography Through Effective Screening, Brief Intervention, and Referral to Treatment at Family Medical Center of Clark County.
Jewel, hold on. We don't see your slides.
You can't?
Is anybody else seeing them? No. I think you just have to pull them up. I think you are screen sharing, but you have to just pull them over.
I'm on them. That's what I'm
Do you have
looking.
2 screens?
No.
I don't move it out of the way then. Like shrink this one and shrink this box.
Can you see it now?
Nope.
Okay.
It's funny because I see 2 layers of people. Oh, you know what? I think, Julie, I swear I think it's right behind you. Can you shrink? Can you hide participants? Click the hide. No, that's not going to work either. Jewel, why don't you go out and come back in? I mean, not out, but just stop screen sharing.
I did.
Does everybody else have 2 rows of people? And mine says you're screen sharing. So Julie, I think you're still screen. Oh, you know what? Stephanie, did you stop screen sharing?
I'm not seeing Stephanie, but I'm seeing 2 of you. Oh, there we go.
Okay, now we're down to 1. But I think Julie, no, Julie's still here. Stephanie left. Stephanie left us. Julie's still here. Joel, why don't you pull it up? Let's try again. I think Stephanie was screen sharing. Hey, Steph.
Am I off now?
You are. I think you were still screen sharing. I think that's what the issue was.
I'm sorry.
That's okay.
Now it won't let me click share.
Sorry,
Now what?
That's okay.
Can you get on?
It won't let me click share now.
Oh, Jules. Maybe pop out and pop back in.
Okay.
Let's wait just a minute for her to come right back in. Yeah, it was funny because I had 2 rows of us. So I think we had multiple people screen sharing, which I don't know. I don't think that works. All right, so we'll just give her a minute. Hopefully she didn't decide to shut down her computer and go out. All right, let me see if she's trying to ping me. Hold on. No, here's Joel.
Do you want me to try again?
Try again, Joel.
It won't let me share.
Ay, ay, ay.
The share box is grayed out.
It's what?
It's grayed out. Like I can't click on it.
Huh. Somebody else see if they can do it.
Okay, I'm gonna try.
That's Whitney?
Yes, ma'am. Can you see my screen?
Well, it's coming.
Can you?
There it is. Yep.
Oh, okay. So.
All right, Whitney, why don't you go ahead, Julie? I think it's you. I wanted to make sure it wasn't just the thing in general. But you know, Jules, make sure you're paying attention, and then we'll catch you. We'll try the next round, and we'll keep trying you. Maybe it just needs to go off. So let's see. Stephanie, can you help me keep time? Whoop. Okay. Whoa, Whitney, where did you go?
I'm right here.
There you
Can
are.
you still see it?
Yep.
Okay.
Whenever you're ready, Whitney.
So I can go?
Yep.
Okay. My name is Whitney and Graves, and my project is implementing pre-screening and vaccination uptake at a Kentucky health center. The aim of my project was that Planned Parenthood will improve screening and effective care for HPV to 80% for males and females aged 18 to 45 within 90 days. The plan changes tested included having a kickoff quality improvement meeting the first week, followed by weekly team QI huddles, a shared decision aid, which was HPV, should I get the vaccination, a modified CDC HPV decision tree screening checklist, and a case management log. My predictions were that the team huddles will improve communication and increase team participation, that the patient aid would increase their chances of being vaccinated by enhancing their knowledge about HPV and HPV-related diseases and vaccines, and that the screening checklist and case management log would help identify the patients needing the vaccine, provide appropriate interventions, and help us keep track to make sure we're doing appropriate interventions. And this is my team, excuse me, run chart. And we started off with the QI huddles, and then due to team's low morale, I started doing short one-on-one meetings and regular project updates, and that increased our morale, improved communication to 100%. The percentage of patients identified as needing vaccines, the baseline was at 15%. And throughout the project, we implemented such things as laminating the form and putting it on bulletin boards, and even started handing out a sheet where it has pictures of genital warts and things like that. And that increased the patient percentage to 83%. By implementing all these interventions for our Right Care bundle, it went from 10% in the beginning to 96% at the end. The key interventions including encouraging the team members one-on-one and doing texting my team regular project updates. The summary of results. The screening checklist showed that the percentage of patients identified as needing the HPV vaccine decreased from 94% during the first cycle to 83% during the life cycle. The decrease was probably due to the rise in the number of patients being screened. Patients found that the shared decision aid was very helpful in assisting them in making their decision in getting vaccinated. The average score was 86%. The case management log documented 28 patients who received the vaccine, and an average of 83% received the Right Care bundle. The weekly QI team huddles were effective in improving team communication from a baseline to 66% to 100% during the last cycle. Learning. The team huddles were effective in improving communication and increasing team participation. The team really appreciated having pertinent information in such a short period of time without having to sit down and have a formal meeting, without interrupting their workflow or like bothering their lunch or making them come in on a different day. The patients enjoyed the decision aid. It was very effective in helping engage the patients and increase their knowledge about HPV and the vaccine. The screening checklist and case management log were very effective in helping us identify those who needed the vaccine, making sure they got the vaccine, and tracking our interventions. And therefore, by increasing the people who were getting vaccinated, we improved patient outcomes because we were decreasing their chances of getting HPV or the HPV-related diseases. The impact on systems. During the 8-week project, 28 patients received the vaccine. Our team was able to exceed our goal of Right Care by 3% from baseline. The project could be generalized to other Planned Parenthoods or just any clinics trying to increase their HPV vaccination rates by making sure they have access to the materials like the HPV checklist and the aid, and just making sure you have a motivated staff. Conclusions. Planned Parenthood was able to increase the number of patients aged 18 to 45 who were screened and provided effective care of HPV to 83%. This project can be sustained because the only things that you really need are like computer paper and a printer to make the copies of like the screening checklist and the shared decision aid. To reduce future costs, you could laminate the paper and laminate the forms and place them in high traffic areas and maybe have some extras so just in case the patients request it, you can hand it to them. Another vital component to sustainability is making sure you have a motivated staff and making sure that they're willing to use these tools to screen and educate patients. Reflection. I learned that quality improvement is ever changing. I also learned that it's very tedious, it's very difficult, it's hard working. It's one thing when you're doing your day-to-day activities with team members, but it's very different when you're trying to motivate them to do a project that you know is important and important for the patients. And especially at our clinic, we were having our organizations going through some unfavorable changes, so our team morale was low. Taking the time out to meet with them one-on-one and just let them vent and get everything that they had out was huge at increasing morale and gave them the boost that they needed to finish the project. The screening checklist was very effective. It was quick at identifying patients who needed the vaccine. It was very favorable among the team because it was only one page and easy to use. The shared patient decision aid was also effective in educating the patient. The patients found it to be very informative. However, they did not like the fact of, having to fill it out and turn it in. And lastly, the staff thought the case management log was easy to use, but they also mentioned that they would have just rather give up the log and just prefer the interventions in our electronic medical record system. And I am finished, but I just have a couple more pictures that I just like. And I am done.
Great job, Whitney. Thank you. I got 601. How about you? I think it was Stephanie. How'd she do? Oh, you're muted, Steph.
558 I had.
Great. And nice pictures, Whitney. I like those. I was looking at those beaches thinking, man, that looks awful nice.
That's where when I was doing this, I was like, this is where I want to be. This
Yeah,
is where I want to be.
That looked really nice. Really nice. All right. Good job. Julie, can you get it up?
Maybe.
Is it grayed out still?
Yep.
Ay, ay, ay. Julie, you may need to try to go all the way out and come back in. I'm not sure what happened. Oh, you're muted, Jewel.
My computer wants to update if I shut it down and restart.
Can't you tell it no?
I don't know how to do that.
I tell mine no all the time.
It doesn't give me an option for no when I tell it shut down or restart.
Well, I don't know what to tell you, Jewel. Anybody got any suggestions for her? I mean, mine says, do you want to update now? And I say no.
Mine just says update and shut down or update and restart. I don't have a choice to.
Can you just go out of the internet and then come back in?
I wonder if that's why it's not, I wonder if that's why it's not letting you to do it.
I did that last time when it didn't work and I got out of the thing.
Well, my only thing, it's like the off on button, unplug the computer. My only thought is to go out and come all the way back in.
If I turn it off and then it wants to update, can I call in and listen? Is there a way for me to?
I don't know. Cheryl, did you have a thought?
Do you have Windows or Mac, Julie?
Windows.
Oh, not much help there then.
And I don't think you can call into this, Jewel.
Okay.
Unless somebody's got something.
You can get the I get the app. I have the app, so like sometimes when my internet goes out, I can do the app, and then I can still see you all.
So the YouTube app?
No, what is this? The Google
So Julie,
app.
if you go over to the three dots underneath all that stuff, is that grayed out? The chat box, the screen share, the wrench, yada, yada, yada. There's three dots there.
I don't have anything underneath that.
Jewel, I don't know what to tell you.
I know a lot of times with Apple, if they have an update, it can just be like a couple minutes. But then again, there's always that one where it's a monstrous update.
Yeah, I don't know what to tell you.
And I restarted before this just to make sure I wouldn't have any problems.
Well, it happens to everybody. So why don't you, let's see, links. YouTube page, video embed. I think that's not going to help us. I don't think there's a phone number here, Joel.
I'm wondering, could she send her PowerPoint to one of us? I mean, this isn't ideal, but may send the PowerPoint. We could just somehow move it forward or something.
Send it to me, Julie. Great idea, Cheryl. Cheryl, I love that thinking. While she's doing that, Nicole or Cheryl, would you like to go?
I'll go.
Okay, Cheryl. And then Nicole, have you done timekeeping yet? No, could you do that for me? So Cheryl.
Okay. How you seeing it? I'm seeing it right now.
I did see it. It just went away.
There we go.
There you go.
Okay, you got it now?
Okay, let me just get my timekeeping ready.
My
Hold
name is
on.
Cheryl Gould. Oh.
Hold on one sec. All right, go ahead.
Okay, my name is Cheryl Gould, and I'm a psychiatric nurse practitioner. And my project was implementing right care for effective tobacco treatment in an urban mental health clinic. I work at a clinic in Bedford-Stuyvesant, Brooklyn, or Bed-Stuy as we affectionately know it. And I work for a company called Services for the Underserved. The aim of my project was to increase the rate of tobacco management for clinic patients using Ask, Advise, and Refer, 2A's and R, from 25% to 90% in 90 days. The planned test of change, first one is screening, which is the Ask part of the 2A's and the R. These are some of my teammates, two of the therapists, our medical director, and our QI director. The next planned test of change was patient engagement. And for this, we used a shared decision-making tool, which down at the bottom, it had whether you wanted to discuss tobacco treatment now, not now, but maybe at the next visit, or yes, I want to discuss my options now. So basically it was, how do you feel about smoking and what do you want to do about it? The next planned test of change, which was the advise and refer part of the Ask, Advise, and Refer, was a Right Care case management log. And the final, and in a lot of ways the most important planned test of change, was team engagement. And the primary intervention with this was a biweekly tobacco team QI meeting. There's my director, my mentor, Brenda, and another one of our therapists. Predictions. Implementation of the Ask, Advise, and Refer checklist, the shared decision-making tool, and the case management log would increase tobacco management to over 90%. The tobacco team QI meetings would increase team engagement by providing tobacco education and training, soliciting feedback on process implementation, and including administration in the tobacco treatment program. First run chart I have here is tobacco management using the 2A's and the R. This is the AIMS run chart. And after the introduction of tools to track screening, intervention, referral, the mean score for tobacco management was 91.5%. So the use of the tools was effective for increasing implementation of tobacco treatment. The tobacco screening, the mean score screening was 32.4%, which unfortunately we did not even come close to reaching our goal of 80%. But with the spread of the screening to the therapists, after initially dropping in PDSA 3, which you can kind of see here, combined with a snowstorm, the number of tobacco users identified did start to increase, and you can kind of see the trend going up here. So optimistic about this trend continuing. The patient outcome, I thought this one was very interesting. The mean score for decisions to quit, which was the yes, no, maybe, was 72.7%, which was below the goal. But the interesting thing to me was there was no discernible pattern to indicate the impact of the different interventions on the results. And you can see I have different, interventions here, and none of it makes any sense. So the Right Care CML, the case management log, the spread to therapists increased the percentage of right care, resulting in an increase of the mean score from 81.6 in PDSA number 1 and number 2 to 83.25 in PDSA 3 and 4. But the mean was still slightly below the goal of 85%. But we were definitely going in the right direction as far as getting diagnoses, treatment plans, and all of that in also. Summary, screening. Total of 271 patients were screened, with 93 tobacco users identified for intervention and referral. The brief intervention of the shared decision-making tool increased discussion of tobacco use and treatment options, and the majority of tobacco users were advised to quit and referred for tobacco treatment. Team engagement, the QI meetings were an effective way of increasing engagement, and we also added some, like a Tobacco Thursday, and a couple of we created a bulletin board for the waiting room as a team. Learning, screening increased significantly, but we still only screened about 50% of the patients, and an EHR prompt would have been very helpful. Like I said before, the tobacco discussions, there was no correlation between score and interventions. And Right Care, the prompts, which I had on paper, were very helpful in keeping everyone on track. Impact on the systems. Patients definitely increased dialogue about tobacco use. On the site, it really helps to foster a tobacco-free culture, which is very important with the type of patients I work with. And on the team, just increased engagement, teamwork, and awareness of tobacco treatment itself. The conclusion, outcome of the project, it was mixed. It was not as good as I had hoped, but it was definitely better than my fears. And, discussions about tobacco use have increased. Big question, is it sustainable? Ideally, yes. In reality, might not be due to a really bad EHR we have. Reflection, some of the factors that promoted success, the camaraderie and dedication of the team, that was the most important thing. Barriers to change, staff time constraints, conflicting priorities, and a really bad EHR. And as a DNP leader, I had no problem with the older staff, and by older, I mean ones who've worked with me for a while. New staff was kind of difficult, especially one of them. And what I learned, team morale and buy-in are essential, and you need a champion. I actually had 2 really wonderful champions. And then this I just kind of added because it reminded me of nursing school. Tell me and I forget, teach me and I may remember, involve me and I learn. So I am done.
Great job. Very nicely done. And I got you at 6:30 something.
Yeah, I had
Nice job.
6:34.
Nice. You had a really nice pace there. Oh, we just lost Whitney. You had a really nice pace there, Cheryl. That was very well done.
Thank you.
Okay, Jewel, let me see if I can download this so that I can then have it. I may not actually need to download. Let me see if so if you could unscreen share.
Okay. There we go.
And then I will try to screen share, except there we go. Let's see if I can, maybe I don't have to down this. You let me know, guys, if you can see this. Can you see that? And you're gonna have to turn your mics on because I can't see you now. Yes, no, maybe?
I can see it. I don't know if they can.
Yeah, we can see it.
All right. If I can fill the whole screen here. I guess that's as big as, is that big enough? Can everybody see?
If I talk, is it going to go away?
I don't know because I can't see anything. Talk and see if it goes away.
Okay. Can you all see it if I'm talking right now?
No, it's going away.
Okay, let me download it then. No worries. No worries. I just thought maybe we could sneak by. It'll just take a second.
I have to be the difficult one, you know.
You are difficult, Julie. We know that.
As long as we all know it, it's good.
I just want to let you know my computer just shut down, and no, you can't stop the update.
Oh, no.
Random side note.
Well, I'm glad I didn't try because then I'd been like, does anybody know that I'm not ever coming back?
Yeah, I was like, what's happening? And I was like, oh my gosh.
Are you on the app now, Whitney?
I'm on, yes, ma'am. I'm on the app, but I'm trying to, I'm waiting on my computer to ignore my desk is dirty, but I'm waiting on the Windows to load back up.
Julie, let me put this in documents and save it. All right, guys, I'm coming. Okay, let's try this. Back to here and screen share. Oh, I don't need to. God, it's been so long since I've done this. I have to screen share and then have it on my desktop. Duh.
No, here it has me all of a sudden. There we go.
All right, hold on. Oh, dear, dear, dear. All right, I'm having a brain fart. Why can't I do this? I need to pull it up. It should be right here. All right. You can see it?
I can see it. Can you all see it if I'm talking?
Does it go to Julie when you talk?
You know what though? I feel like if we click on your screen, won't it?
Yeah, you have to click on my screen.
Now, Julie, talk really quick.
Okay, so can you all still see the screen now?
Yes.
Yay!
Are we good? Okay, so Jewel, I can't see anybody, so just tell me when you want me to switch sides, okay?
I'll just say next
Yep.
when I'm ready.
That
Okay.
works.
Okay.
Somebody do timing because I can't do two things at once.
Okay, whoever's timing, are you ready?
Yes, I'm ready.
Thanks, Joe.
Hi, I'm Julie Percival. Welcome to my presentation on our quality improvement project, Improving Mammography through Effective Screening, Brief Intervention, and Referral to Treatment at Family Medical Center of Hart County. Next. Family Medical Center of Hart County is a privately owned rural health clinic located in South Central Kentucky. We currently have 1 physician, 1 pediatrician, 5 nurse practitioners, and a support staff of 50 individuals. In addition, our facility has an in-house lab and x-ray department and prides itself on the care it provides to our community. Next. The rate of breast cancer and related mortality is locally higher than the state or national rate. We identified that the rate of screening mammography within our facility was 46% lower than the national rate at only 25%. Next. The aim of our quality improvement project was to increase the rate of screening mammograms and right care at Family Medical Center of Hart County to 55% of eligible patients in 90 days. Next. Planned tests of change began with weekly quality improvement team meetings, and the use of rewards was implemented in Cycle 2 as an incentive to promote team engagement. In Cycle 3, run chart data was utilized in meetings to engage attendees, and by Cycle 4, data was spread to all staff to increase awareness and participation. Next. The screening test of change included screening and identifying patients with the use of an electronic health record reminder, which identified female patients 40 to 74 years of age without a mammogram in the last 2 years, and use was spread to all triage staff in Cycle 2. Simulation of the process and approach to patients was conducted in Cycle 3, and by Cycle 4, screening was spread to all providers. Next. The patient engagement test of change involved implementing use of a decision aid to determine the patient's risk of breast cancer. In Cycle 2, use of the decision aid was spread to all triage staff and posted in the waiting room in Cycle 3. By Cycle 4, use was spread to all providers, with breast cancer statistics and signs of staff posted to personalize and promote patient engagement. Next. Lastly, a case management log was initiated in Cycle 1 and maintained throughout implementation to track patients and right care components. Patient demographics, mammogram appointments, no-shows, and provider identity were added in Cycles 2 and 3 to determine if any disparities existed. By Cycle 4, appointments after implementation were noted to continue tracking for right care. Next. Predictions included use of the EHR reminder to identify and screen patients, a decision aid for patient engagement, a case management log to track right care, and full team member attendance at weekly meetings. Potential barriers included resistance to change, patient disinterest, missed opportunities, low rates of right care, along with poor communication and low attendance at weekly QI team meetings. Next. Throughout implementation, we learned that utilization of the EHR reminder is an effective tool to increase screening mammography rates when it is used consistently. The most effective test of change was sharing run chart data with staff on how well they were screening patients, which resulted in the largest increase in screening in Cycle 4. Overall, the average rate of use was 40%. Next. In regard to patient engagement, we learned that the use of the mammogram decision aid tool is an effective method to increase patient engagement and shared decision making. The average rate of use of decision aid was only 26%. Despite the low rate of use, patient confidence rates regarding their mammogram was high at 91% according to the SURE survey results. Next. Average rates of right care were 27%, with a portion of results still pending. The largest improvements in the rates occurred after patients that had not kept their original appointment were able to be rescheduled and results received. The current process is in place within the facility, and the EHR effectively track and contribute to right care for our patients. Next. We learned that utilization of standing orders effectively increases the rate of screening mammography, with total mammography rates reaching an average of 43% and standing order rates at 33%. When standing orders are used consistently, the total mammography order rate surpasses the state rate of 59%. Next. Screening rates rose to 40% and patient engagement increased to 26%. Processes were standardized and increasing the mammography rate to 35% and right care to 27%. Team meetings resulted in effective teamwork, with scores reaching 100%, proving it takes all the pieces of the puzzle and everyone working together to create effective change. Next. Resistance to change resulted in lower than expected results in all ramps. Team member communication and contributions were limited despite incentives. Sharing data with staff revealing the utilization rates resulted in the largest improvement in the process changes. Overall, rates in each core intervention improved, but the barriers encountered limited the impact and the likelihood of sustainability. Next. During this project, 413 patient charts were screened, with 78 identified as eligible for mammography and tracked for right care with effective patient engagement. Although overall results were less than predicted, this project is generalizable to any preventative healthcare aspect where expert can be utilized with the adjustment of the decision aid and staff willing to participate in health promotion. Next. The rate of screening mammography and right care at Family Medical Center increased to 35% of eligible patients in 90 days, below the goal of 55%. The sustainability of this project is possible on a smaller scale with planned continued use of the EHR screening reminder, use of decision aids by providers only, and continued tracking of right care through processes already in place. Next. Factors that assisted in the success of the project included the ability to create our own EHR reminders, enabling us to focus on a specific population of patients and create standardized processes. Implementation of an easy-to-use decision aid assisting patient engagement, while right care processes were already in place and able to be standardized and monitored to ensure accuracy and completeness. Next. Barriers were encountered initially with providers determining which evidence-based guideline would be followed, then with staff that disagreed with the guidelines chosen. This led to continued resistance to change throughout the project, causing ineffective communication and collaboration and poor utilization of the core interventions. Next. The need for continued meetings with all stakeholders, including management, providers, and staff, provided growth and a learning opportunity to improve communication techniques and how to be flexible in my expectations. In addition, I learned to appreciate the positive and negative contributions from others to assist in process changes, and that any level of commitment and support is invaluable. I'm finished.
Good job. All right, let's see if I can get out of here. You know, it's so funny. I'm doing these all the time, and do you think I remember how to do it? Oh, goodness.
Thank you for sharing that slides for me.
You're very welcome. Thank Cheryl for thinking of it. All right, so now I have to stop screen sharing. Okay. All right, Jewel, well done. And so Nicole, are you the only one left? You're muted, Nicole.
Do you want Julie's time?
Yes, please.
It was 6:41.
Thank you.
It was all those next that added to my time.
It was,
You know,
yes.
it actually could have been. That's
Well,
very
because
little time.
I was at 6:33 before that.
So 7-8 seconds more wasn't bad.
That's right. That's right. Nicole, can you get yours up? And you are muted still.
Can you hear me now?
I can hear you and I see myself.
Okay, let me get to my screen and you may not see yourself anymore. Okay, can you see my presentation now?
I can. Who has not done time for me? Jules, can you do it for us? Sorry, Julie, that was my roommate in college, and so we always called her Jules, so I don't mean to shorten your name.
That's okay.
All right, whenever
I always
you
say
are,
Jules too, for
Yep.
the one at work. Yeah.
yeah, whenever you're ready, Nicole.
Okay. Hi, I'm Nicole Wilson, and my project was on increasing well-child examinations and recommended vaccines through the promotion of effective care in a rural health clinic in patients aged 7 to 12. My project was set in rural West Tennessee. Excuse me. Choosing this topic was based on the need of our pediatric population for them to complete the annual wellness exam and the recommended immunizations. The reason we focused on the 7 to 12-year-old age group is research has shown that until they need immunizations, they do not usually come in for routine preventative care. PCMH level 3 is what we currently are, and this is one of the measures that we track, is another reason why this topic was chosen. The aim is that there will be a 21% increase in well-child exams and recommended vaccine rates with the implementation of screening, brief intervention, referral, and treatment with the Right Care Bundle at Lifespan Health Medical Clinic for patients aged 7 to 12 years by March 8, 2019. The plan test to change for the team, we started out with a weekly QI meeting, which went really well. we have a QI team that has been established for a while and worked on several projects, so that was really easy. The second PDSA cycle, we worked on a prize drawing of completed surveys, because that was one thing, is that I was not getting good results on the surveys. Everybody was marking 5s. There really wasn't much information on what we could do to improve. The third cycle, we did a role play with vaccines. I live in the rural South, and the religious cultural context discussing HPV vaccines was identified as a problem and one of the main reasons why patients refused that vaccine. And then we finally, our last cycle, we did a daily team huddle. It was identified that when staff was absent, some of the nurses might not have known and forms weren't given out like they should have been. For patient engagement, we started with implementing a patient engagement tool. This worked really well. The patients seemed to like it. I even had some that were not pediatric patients that were asking to use the form. So the second PDSA cycle, we did a retrain on this because there's a teach back on the back of the form that the providers are to mark what the patient or the parent was able to demonstrate that they learned, and that was being missed. The third cycle, we did an HPV vaccine information sheet, because a lot of the parents, like I said, this is not a required immunization. So they were kind of not wanting to get it. They wanted more information. So we did 2 easy handouts that I received from the CDC that were based on literacy. They were easier for patients to understand. And then the last cycle was we had planned on utilizing the patient portal. This didn't work very well because a lot of our patients that needed to be contacted via the portal had not signed up for it. So in regards to screening, the first cycle, we implemented a pre-visit screening checklist. The second cycle, we spread it to the new care team so that we could reach more patients. The third cycle, we did some modifying of it. The team had suggested some addition of information on it, and we added that. And then the last cycle, we screened patients that were added to the schedule. We had been screening at 100% since the implementation of the screening checklist, so we wanted to see if we could reach even more. And then for the follow-up, we did a case management log. We started with the implementation of that, and then the MA was to schedule the patients instead of them having to remember to stop at the front desk for their follow-up. Then we did a follow-up. The next cycle, we added a follow-up call for patients that missed their appointments. And then the last cycle, we ran reports out of the electronic health record to call the patients that were deficient in care. The goals and objectives, the predictions. We had set the aim at 50%. We started with a baseline of 21%. We're hoping that the team satisfaction and engagement would be about 80%, which we did achieve that. The patient engagement tool, we hope to be utilized at 50% along with teach back of 50%. We also hope that on the screening, we would be screening at least 75% of the patients that were coming through the clinic. We reached that goal and exceeded it. All 4 cycles at 100% of patients that were scheduled that morning were screened. And then the last cycle, when we added the patients for the day, they also were screened at 100%. The follow-up, 100% of patients were entered into the log the entire time. And our goal for the receiving the right care bundle was 50%. So for results, patients that were due for well-child exams that were noted on screening, as you can see, we noted several of them. Each cycle, the very last cycle, there wasn't the very last of the cycle. There wasn't anybody that needed well-child exams that were screened that day. We had a flood in the area, which kind of decreased our patient load some. So for those that are due for well-child exams, my goal was to identify 75%, and our median was 62% of the patients we screened did not have an up-to-date annual exam. So for the immunizations, it was the same thing. 29% was the median on those that we screened that did not. Of course, we were doing the 7 to 12 age range, so they don't need the immunizations that we were looking at until age 11. So for the right care bundle, the very last cycle, I'm really proud of that. 100% of the patients that needed it received it. We only excluded 1 out of 11, and that was because they had a fever. But on average, 58% of the patients received their right care bundle. So summary of results. As you can see, I did not reach the original predicted goal of 50%, but we did improve. We had to trend upwards the entire project cycle. We completed 21 annual exams in this section. So we continue to show improvement the whole time, which I'm very proud of. The well-taught exams, you can see, even though the composite average is not at our goal, we did achieve greater than 50% on here. So my learning. I learned that sometimes getting patients to participate in their own healthcare is very difficult. If we didn't reach our goal, we still made a change. Sorry, I know I'm running out of time. I'm trying to hurry up. So impact on systems. These are generalizable. It's effective for the 7 to 12-year-olds, and people need to see this. Oregon had their first child case in 30 years of tetanus due to non-immunization. There is a lot of false information out there, and because of that, there are a lot of people that are not receiving the correct immunizations. So my conclusions are we developed a standardized process that is effective right care, and I didn't reach my goal, but we still improved. So you may feel like sometimes you're caught in a herd of sheep and that you feel like everything's been dumped out on the trampoline and you can't find anything. But at the end, there is a light at the end of the tunnel. And if we just keep striving, we can do whatever we want. Thank you.
Okay, well done.
Sorry.
A little bit over, but well
Yes.
done.
Sorry.
Like those pictures.
This warrior dash was one of the hardest things I've ever done, and I will not tell you my time because I'm embarrassed by it, but I'm just glad I finished it.
I'm impressed that you finished it. What does it include?
It is like a 5K, but like I said, I live in rural West Tennessee, and so the mountain basically that we had to climb was what was the hardest part. The barriers, the going over the walls, the things like that weren't that bad. It was that hill that just seemed to never end.
Wow.
That about killed me. So
wow, impressive, impressive. Well, good job, everybody. Okay, everybody take a sigh of relief. You are done with that. You did a very nice job. And I just want to debrief for a little bit and sort of talk about, you know, how it went. You know, a couple things that I noticed. Julie and okay, I'm missing it. Context was Julie and somebody else, but Nicole and Whitney. Oh my God, I've just lost my notes completely. I was talking about context. Julie had a hard context. You know, she had an uphill struggle. Did anybody else have that? Oh, I think Cheryl. I think that was what I was thinking, is that difficulty with you know, your team, your administration. Cheryl, your team was really good, but your EHR was really your barrier.
No, yeah, the EHR basically had nothing to do with this project at all, because nothing could be, none of the forms could be added to it or anything else. My project was 100% done the old-fashioned way with paper.
And you know what? Works just fine that way. Oh, I know what I wanted to ask everybody. Can you just go down the row and tell me how many, if you did a screening, like what your big number was, how many screened and then how many treated? I just want to look at our total numbers. Stephanie, what did you get? It doesn't have to be exact, roughly.
I had 183 kids screened and 96 received right care.
And Julie?
I screened 413 charts and 78 were identified and had a mammogram ordered and tracked for right care. There was a percentage that we missed that I don't know that off the top of my head.
Great. And Whitney?
I want to say maybe 50 were screened. I have to go back and look, and 28 got the right care.
And Cheryl?
271 were screened, 93 were treated, had right care.
And Nicole?
124 were screened and 79 had right care.
So we have 2, 6, 7, 8, 9, 1,000 people that you guys screened. 1,000 people that the 5 of you screened. That is wild. And then another 1, 2, 3, almost 400 that received right care. So really well done, really well done. And you should feel very, very proud of yourself. You not only learned this process, pulled all that data together, but you really did affect population health. And that's very, very impressive. And that's the whole point here. So I want to be quiet for a minute and just see if you have any questions or comments for each other. Let's start with questions first. Do you have questions?
I have a question. I did all pictures like that. Was that what I was supposed to do?
It was fine. It was
Oh,
fine to
okay,
do all
because I was
pictures.
getting nervous when I was seeing other people's, because I just kept thinking I want to be by a beach. And then I was like, I really wanted to put ice cream on there, but I was like, I'm going to skip that.
No, there wasn't really a wrong here as long as you addressed each section, which you did.
Okay, I just wanted to be sure.
Yes, yes.
Whitney, I would have loved ice cream on there if you'd have done that.
See, and I was going to do like a pizza because I was like hungry. I was going through a lot at that point.
So tell me some things that struck out at you about how people presented or what they presented or how their pictures went with their words. I will tell you the one thing, and I can't remember who do it. I think it was Julie who presented her process and her outcome run chart together. I really liked that. What else? What kind of? Oh, go ahead.
I thought Stephanie did a good job with the use of her graphs. I started to put mine on there, but I had difficulty getting it. But hers, it flowed well with her speech, and it was very visual. So
Great. Yep.
I will say that I am jealous of those of you that can present without getting nervous and going over time, because I got behind here. I am the electronic health record trainer for our facility, and every month I have 30 minutes with all the providers, and sometimes I have the whole entire staff, and I can do that fine. But for some reason, this small group of people that I do not know other than through here make me nervous. So I apologize for that.
Well, you did fine. I think that Cheryl was the best pace. Cheryl she wasn't hurried, and she seemed to get everything that she needed to say. Cheryl, how did you achieve that?
I've done a lot of public speaking, just from teaching and stuff like that. And I practiced with the slides.
Do you guys practice with the timer?
I did, yeah.
In
the slideshow view.
And how does everybody else find that? Is that helpful for you?
very.
Did any of you practice in front of other people? A partner, a friend?
I practice in front of my dog.
Dogs do not count.
She wagged her tail, so.
My coworker crashed me practicing at work today and sat in and listened, and I was like, no, because I need to focus and you're distracting and I don't need you here. But
so I had one of the 742s who presented her final project today. I said to her last night, she gets very, very nervous. So I said to her last night, come on, come and practice in front of me. And then it will be at least one person that you've done this in front of. And I'll tell you, last night it did not go well. And I was very worried about her today, but she pulled it off. So it is, I'm the same way. I don't like to practice in front of anybody else. I just practice it. And then I feel like I'm also a relatively good public speaker, but in that I don't get very nervous. But it is really good practice to do it in front of somebody and to have them like, did you understand what I said? Do you have any clue about what I was talking about? What are some other tips of how you do this well?
Ativan? I don't know. I haven't tried that, but I'm willing to.
All right. So let's see what else I wanted to put here. Oh, the thing that I also thought Stephanie was very positive. And as I listened to final presentations, both here and the finals, I am always surprised that we don't want to not say what we didn't do, right? You don't want to falsify what you've done. But there's nothing wrong with saying, I had an initial goal of 75%, which was way too big of a jump to make. Because if you remember, it's one of the things that you can look at. And when we began this last year, how do we make that prediction of how much? And I said, well, on average, 25 to 35%, depending on what you're trying to do. So you can always, in the beginning there, say, wow, we're not going to get there. That was way too much, and bring that goal line down. And so I would encourage all of you to not state what you didn't do. I didn't make my goal of such and such. Just say what you made. People can see where your goal line was. I think at this point, changing your goal line is somewhat silly, but I would just state it as the improvements that you did make. Everybody had some improvements in one area or another. And that people can see. They don't need you, just like they don't need you to read your measures to them or read with the run chart. You see, I went up to, they need you to give them the overall. This is the summative. So look at your goals and what you have accomplished.
I just wanted to add something in that same line of thought. That was one thing that I picked up with Nicole too. You made it very personal you talked about how proud you were, and that made me just feel like this project really meant something to you. And it wasn't just an assignment that you did for your doctorate. It was like something that you really wanted to change. So I thought that was
really
I like what you said about the importance of getting immunization. Yeah. And about how you're bringing the current about how people aren't vaccinating their kids now, and how we're getting the measles and the tetanus and all these diseases.
We just had a case of measles here in Tucson.
Oh.
Well,
where they're talking about the one in Brooklyn, right near where I work is where Crown Heights, which is a heavy Orthodox population, and they had one kid infected 22, and that was as of last week.
Wow.
So big problem here.
The article on the Oregon boy, the first case of tetanus in a child in over 30 years. He spent, I don't know if y'all have read that article or not, but he spent 42 days in intensive care. He of course was unvaccinated, got cut on the farm. Parents just sewed him up themselves. And then within a week he had tetanus, and he spent 42 days in intensive care, and they still refused tetanus vaccine. It was a cost of $800,000. Just think of how many people could be vaccinated for $800,000.
Wow. Yeah.
Yeah. It's funny that it's very timely. I had my centering pregnancy group last night, and that's, for those of you who aren't in maternity, that's you do their OB care in a group setting, and there's topics that we work on every night. And last night we're through birth, even though they're still pregnant, and talking about babies and immunizations and circumcision and all that stuff. And I tried to not make the one couple who I knew were not immunizing feel badly. And it was, I think, a really good conversation, but it's hard to not have your own personal feelings come into that, and to be able to, listen to that third leg of what is best evidence. It is the best evidence that we know, our experience, and their preferences and values. That's really hard sometimes to give voice to. Yeah. Well, good job. And Nicole, I liked your bar graphs. I liked having a little, sometimes that is a better way to show things. And so even though this is rapid cycle improvement, which we want to show time over, I think throwing in one other, she also had some pie charts in there, if I remember, throwing in some other types of, if that's a better medium to show something and to present it in, as long as you have a majority that are run charts, because this is over time. But I thought that was very appropriate and showed very nicely what you were trying to present.
I tried to separate them out on the run chart, and it just didn't look right.
Yeah.
So.
And then I think it was Julie. I forgot about it, but Julie, I think you had the slide with the multi data in there.
I tried it.
Yeah. I think that on the slide, I think it worked okay. What do you guys think? Julie and I have been debating, because you remember Julie's got the pre-op and the post-op and all.
It looks better than what I remember when we did another point you were doing it, but this one looked really good. And I liked your bra cape that y'all had. Was that a bra cape in one of your pictures? I liked that. I was like, oh, that's cute.
So one of our staff members just completed her breast cancer treatment, and it was part of celebration and team engagement along with it, and we got a boob cake.
Oh, that was it.
Did your nurse manager ever get any more supportive?
I was just thinking the same thing. Which one was that?
It was Julie's, I think.
Yeah.
No, so, which person in the pictures was the DON?
Oh,
the evil DON.
Yeah, kind of blonde. She's in every picture. So if you look at that, each one of those pictures, you can pick her out. She, I thought we were doing really good. Towards the end of cycle 3, into the first part of cycle 4, we started having an increase. Staff was mad about me telling them you're doing poorly, and so they were really trying to prove me wrong. And I thought, we've got this. And March the 5th, we had a meeting, and she said, I've been meeting with to administration, and we have decided that since the providers, the process was they come into triage and see the reminder and the staff orders their mammogram or addresses it. If they weren't, then the provider is trying to catch that. The providers didn't want them to change that if the patient refused, because they were like, we'll just repopulate that in a year. I said that defeats the purpose. We're trying to stress the importance, continue the screening. The providers wanted the reminder to stay on the chart. So her answer to that was to go to administration, and they developed 2 reminders. One for the providers to continually see as long as they wanted to see it. One for triage that they can mark it as completed, and it would repopulate in a year if the patient refused. So we dropped horribly that last implementation point because of that. They started not addressing the reminder at all.
Well, you know what? You keep your run charts and you show your administration.
We had a meeting today, and when I brought that up, there was just silence in the room. So I said, it is what it is. We have made improvement. We've impacted, this number of people. We are screening more patients than we ever have, albeit not the goal that I had set, but we're doing better. So if that's what it takes, small steps, then I'm okay with that, as long as we continue to do that. And then she proceeded to spend the rest of the day to get charts and data to prove me wrong.
The thing is that if you look at that, you screened 418 women in 8 weeks. And the thing that I will say is, in general, even though Julie found this not to be true at one point, you get more with sugar than you do with salt. So in telling them how many that they screened and how many that they captured, and just keep it positive, not what you didn't achieve, but look at what you did achieve. And that's a comment for everybody. I think that's one of the things that listening to some of the presentations today, the final presentations, I noticed that it's rough to stand up in front of your team and tell them what they didn't achieve. So look to the positive, what they did achieve. And I mean, you can do whatever you want, but I just think it's a easier sell, which is why I started saying areas for improvement versus gaps in care. That goes over a little bit better. All right. Any other questions or any comments about something that you wanted to bring us all aware of?
I'm just really glad that I got to see everyone else's process and how they progressed through all this. It was beneficial learning, because I struggled so much with mine. Like, Stephanie's team was great, and it was like, this is not necessarily the norm, that it can be good. There can be positive engagement and things like that. So I think it was beneficial for me to see those other processes with it.
Yeah. And I have to say, Julie, as the person who read all of yours, I'm not sure what else you could have done. You tried every way in every shape and met with people left, right, and center all the time. I think sometimes you have to say, we screened 418 people and captured 96 people, and that was great. And ultimately, it's their choice.
Right. And those processes are still in place, whether they utilize them or not, it's there. So there's a possibility. Right. So the potential for us to continue to impact people's lives is there.
Yep. Yes. What else did you like about the quality improvement sessions? What else was helpful, or what would you have changed?
I agree. I'll go ahead, Nicole.
You can go ahead. So I like that you email us the recordings, because sometimes we're so nervous we're doing this. I like to go back and watch them again. And that seems to help. Mm-hmm. So I appreciate that. And then just like I said, seeing, you're struggling with whatever's going on in your clinic and all that stuff. But then when you see others, sometimes I'm like, okay, my struggles are not bad. I can handle this. So that helps some too.
Yeah.
But it helps.
I think Julie made us all feel good.
She did. And I have felt so bad for you, Julie. So, but it helps too that each one of us we can give each other recommendations. From when you're outside looking in the window, you see things that when you're inside, you don't see. So that helped as well.
And that is really one of our goals, is to have you. That's why I keep trying to step back, even though I have a big mouth, is to let you guys take over and really be the quality improvement advisors that you have grown into. It's really, really lovely to see. Whitney, what were you going to say?
Oh, no, I was really just going to piggyback off of Julie and Nicole, that I liked it because sometimes I'm sitting here and I'm like, I just don't want to do this anymore. Like, I want to quit. They're getting on my nerves. And I'm like, but you know, you're almost done. And then when I talk to other people and I'm like hearing how you're like, even though Julie, you had this horrible team, but you're still positive and, you know, you're just like, hey, you know, it is what it is. Your mentality is very nice about it. And that's like, okay, I can do it. And being able to bounce ideas off of people and hearing what you all are doing and being like, oh, I could do that. Or I should have tried that. How stupid was I not to even think about that? I like that aspect of it too.
Thank you.
Great. All right, well, let's talk just for a minute. If anybody has anything else to say, please jump in, but let's talk for a minute about the summaries. I know they're due tonight, and probably, actually, it's 8 o'clock, so they're probably already in.
They're due tomorrow night.
Oh, sorry, yes.
Wow.
You just panicked us a little more there.
Sorry.
We were starting to calm down.
I'm going to need that added we discussed earlier.
Well, the best part is I went ahead and did it because I thought that's what we were supposed to do for this. And I was like, oh, okay. Well,
So
I
now
can turn
you
it in the night.
That's now you get to think about it. So what questions do you have about the summaries?
Well, I'm kind of like Nicole. I did mine along with this to kind of coincide. I mean, so do I need to go back and tweak things from what we discussed tonight?
That's up to you. You certainly can. You don't have to. I mean, you always have the option of doing that. Remember, it's in the past tense. Remember that the project is done. So you're talking about our predictions were and our learning objectives were, and we learned this. They're all in the past tense. Cheryl, did we decide that did we decide something was in the current tense?
Part of, I think.
Was it the conclusion? Discussion.
Possibly. I'll open it. Let me see. It could have been the discussion or.
Yeah, I think it might have been the discussion. And as you all got better with your citations, I think that you are going to remember to thank me next term when you go to look these things up and have, now you're only going to use a few of them, but you've got them there. Most of you really got the hang of getting some great citations. Did you guys find that helpful? Yeah. Did it help you to feel like a little bit more confident when you presented those options as your next interventions?
Sometimes it guided me a little bit more because like I might have had an idea, but it was like, okay, the lit says this, and how can I tweak that to be what I need it to be, and does it apply? Or, oh, that's a different idea. I didn't think about that. So
right.
That's beneficial.
Yeah. Cheryl, what'd you find?
That one kind of, the reflection and discussion is, we could kind of do in a present tense.
Okay, so most of it is in the past.
They're all basically past tense.
Yeah, okay. And I would also have you take, if you haven't done it yet, if you haven't submitted it, don't panic.
Actually, you know what? The conclusion, one of the sections here is that, can remain at the fore. So it's more present tense.
Okay.
Yeah, that was the conclusion.
Okay, thank you. When you have your aim is really not changed since your beginning, unless it has truly changed. So you don't need to add a lot of things to it. It's for whom, by when, how much. When you put by when, put either within an 8-week implementation, even though you still really started getting that ready last term, or within 90 days, don't put a date. Because as Cheryl and I were talking today, that really confines you. If you're going to present this next year, you don't want it to look old. You want it to, so sort of having that without a date is a good thing to do. Do you have any questions about the summaries? Okay. If you think of things, again, if you think of things that you want to bring up, feel free. Let's talk just a little bit about next term and the Squire paper. You're going to start off, I believe, the first draft is due the second or third week. It's quick. You all have the Squire E&E that was in the course. There's no surprises here. It is really that. The hardest part about next term is, you know how sometimes, I'm going to use Cheryl as an example. Cheryl had a tool that was the 2 A's and the 2 R's. It was ask, advise, and refer, and whatever. That was the tool, but she had to, in her brain, separate this. The ask is the screening. In the paper, you have to separate out what are the interventions, how did you study the interventions, what was the method, what was the context, each little piece, and the whole thing runs together. Just like you saw your team, how often we pulled apart the team, right? Well, the team is involved in the shared decision making, but that's really about the patient and the patient's perception, and how we struggled with that and really trying to separate those two. That's very similar to next term, where you really have to tease things out into their correct categories. So I would encourage you to read the Squire E&E. That's that several page just article. Have the checklist printed up. Do nothing over term break other than that. Just sort of get the flavor of what that is. You might go in and read some papers that were done recently, because of course the papers have been getting better and better and better as they go along. So read some in the Digital Depot over your break, just once in a while, skim through one, see how it did. But the other thing that we talked about, again, I'm going to encourage you to print up your run charts. And just as Julie had this process next to the outcome there, put them on a wall. All of the process, outcome, all the way down, your aim and your balance. And as you have, 2 weeks is not long enough. But I want you to start thinking about walking by those, looking at them. Oh my gosh, I never noticed that when we dropped down on this day, we dropped down on all the days. And turns out that was a snowstorm or the flood that Nicole had. So you would want to, that's a contextual thing that you can put in right in the methods section, in the results section. Often people, you know how you don't put a subheading under a subheading in APA format? So under the results section, often people will put a little intro paragraph where they'll talk about their aim and their balancing measure and maybe one sentence about something that really was important that affected everything, so that you don't have to say it in you don't have to say it in the team section and the screening section and the yada yada. So if there are things like that, and things that jump out at me are Julie's, we've got to think of a very politically correct term, Jewel, but you know, the difficulty when you have maybe a split decision team. You know, we don't have to say that we don't have to say what we're thinking about her or who she is, but you know, you have that divided team, and that could be a way to say that. Nicole, certainly if the flood really impacted your situation. Whitney, I don't think you need to say anything about being away those first couple days, because it really, you know, it was just a couple days. But those kind of things can go in that opening paragraph if they really are something that affect many things all the way down. Then you don't have to repeat it over and over and over. Okay. And then really to take a break, really to like, whew, go to that lovely beach. But if you do go, make sure you bring me. Because you've worked really, really hard, and your brains are exhausted. And you will do much better and come at this fresher if you leave it alone for a couple weeks and really just breathe a little. Go for walks, do all the things that you haven't done in probably 6 months. Say hello to your family again. Tell them that you're going to be a little bit MIA, not quite as much, but you know, enjoy life just a little bit, because what you really need to do when you write is let things filter down into your brain and kind of weed out the things that were important and not important and what annotations were important. And you just have to let it percolate a little while. 2 weeks is not nearly enough to let it percolate, but it's going to give you a rough draft really when you're done that is very close to publishable. So very right off the start, you're going to write a paper, you're going to write it for your peers, and the computer will give everybody a peer person to evaluate. That's a very helpful assignment, because it makes you really look at that checklist and say, this is here, this is here, this is here, which makes you understand what each of those pieces really is. And it's not helpful if you're very, very, very nice to your peers. It's helpful if you say, this part's a little confusing, and I don't see the limitations in here and that. So, you know, it's kindly constructive, but it's constructive. That helps you and it helps them. And then you do another draft for me, and then there's your final draft. So there's 3 drafts of the paper. You're also going to start out, I believe one of the first assignments we call the 4 S's, which is sustainability, spread, something, 4 S's. I can't even remember what it is. But it's where you're going to write a memo to your site about, here's the tools that I use that I'm leaving you with. We talk about deliverables. Remember you talked about benefits way back when and the impact on your site? Here's the tools that I'm going to leave you with. Here's the processes that we've developed. And making that in a very professional and organized method, so that if, for example, if I only want to look at your shared decision-making tool, I don't have to hunt all the way through this paper to figure out where it is. That's one of the things that you want to think about. Brief, concise, but thorough. And you're also going to be looking at sustainability, scale, spread, and cost. But there's 4 S's. It's going to make me crazy that I can't think of the other one. And when you think about cost, it's not that it didn't cost anything for you. But for example, Julie, she saw 418 women and captured almost 100 women who wouldn't have been seen. So what can you extrapolate from that in terms of, or Nicole, who brought people back in who would have been missed? What can we say? Well, an annual visit gets this much, and we get this much for vaccines, and so we can extrapolate that we actually made or saved. If you talk about HPV vaccines, like Whitney, if we vaccinated these people, when you put that problem statement up there, and it costs this much, the burden of disease is this much money. Well, how much did we save by getting these people immunized? So you have to be a little bit creative there. It's not falsifying, but it's not black and white. So you have to kind of create what that savings is. Smoking, same thing, all the burdens of disease. And if you can get people to stop smoking. I
still remember Cheryl's from the very first presentation, the statistics on the smoking. I'm still.
Yeah. It was crazy. Crazy. And then you end up, I feel like I'm missing one. You end up doing a storyboard poster, which we will hope that all of you will consider presenting to IHI. Last term, not this past term, but the term before that, because IHI conference is in December, and then that's the big one. And then there's one, I think maybe in June or July. But the one in December, we had 11 or 12 students submit to that got accepted. And 5 or 6 of those were, they got star ratings and were asked to possibly publish. So it's really, what you're doing is really remarkable, especially in the length of time that you're doing it. We know how hard we have ridden you and pushed you. And I hope I pushed you only hard enough to nudge you a little bit forward and not break you. I don't think I smushed any of you. Certainly that was not my intent. But I think that you all really made some fantastic changes, and you need to get those out there. So that's kind of the gist of next term. We don't meet as much. I will miss you all. It will be very sad for me. You always know where I am. And then your final presentation. Your final presentation will be at your site. That's one of the mechanisms that we have to make sure you actually were there and did this. You will present to your stakeholders. You're asked to have faculty there and peers there, hopefully with this peer group, that you will support each other and come to each other's presentations as best you can. They're often in the middle of the day, so it's hard. And we ask you to bring stakeholders. Don't feel, when you write that sustainability and spread memo, that is something that you could send to the CEO of the mammography, whatever, the American Cancer Society for breast cancer, or, the immunization queen, or, whoever that you find, because you'll be very surprised at who will say, yes, they'd like to come. And even though it's a little intimidating to invite them, it's always or your CEO, or, someone else at another site, the hospital next door, who you've heard is doing a similar campaign. You may want to invite them. So feel free to reach a little bit for those people. I remember I did Centering Pregnancy Ed. I told you that I was at the other night, and I invited the founder of Centering Pregnancy to be my mentor. At the time, we still had chairs, and everybody said, she doesn't take any students. And she did. I mean, shocking. It was pretty wild. So you never know when people are going to be there in your corner. And that's really nice for you to have. So that's kind of the deal with the Squire. They're generally, the presentations are generally like we're doing them today. I had a student today. I have a student tomorrow. I believe I believe they're finished at the end of this week. So they're always, it depends on when you have your meetings. If you have regularly scheduled monthly meetings and you want to hit that, if we can, we want to hit it the end of the term. I think it was you, Julie, wasn't it, who's got one in the middle of her big meeting for her team is in the middle of May. That's hard. I don't know what Dr. Jefferson has said. I wrote to her and asked her, for her opinion because she is the course coordinator. It's just hard on you because you haven't gotten all of those assignments done and back. It's just a little harder. We have had people do it, but it's not something we encourage. However, you really want to present this to your team. And so that's an important best. So we have to weigh those things. So I haven't seen what she said, Julie. But that's kind of the scoop.
How long is the final presentation have to be?
It's supposed to be 15 to 20 minutes. You have a half an hour. So it's supposed to be 15 to 20 minutes. And it's just what you've just done. It's all, it's your data. It's the same thing that you've done. It's your aim. It's your methods. It's exactly following the Squire paper, which is very similar to what you're doing here. It's the standard format for quality improvement. So you have the template and the slides that you have to do. And looking at best practices, it's very scientific. So there are very few pictures in it, if any. You might have one of your team or your site, but other than that, very data driven and, results. I was just going to tell you something, 15 to 20 minutes, and then you lead a facilitated discussion. So I always tell the students, come up with a couple questions in case no one has any comments. It's nice to say, do you have any questions? If they do, I like to get them involved, right? Engaging your audience. But if they don't, you're ready, and then you can ask them some questions. But don't be careful not to jump in with your questions and shut them off. Sometimes they really do have some great conversations they want to have. And you can invite anyone, family comes, whoever you want. And that's kind of the scoop. What else, guys? You're all exhausted. I don't blame you. You've worked really hard.
Dr. Butler, I'm going to Dubai on Saturday if you would like to go.
You're going where? Oh, Dubai?
Mm-hmm.
What are you doing in Dubai?
Rest and relaxation.
In Dubai?
I was there in December and January.
Wow.
It's wonderful.
Is this like a common place people go?
No.
Yeah, I didn't think so.
It was on my bucket list, and I said, let's go.
Good for you. And yes, I do want to go. I wonder if my husband's listening and he can.
You have to go to the Dubai Frame.
What is that, Cheryl?
It's you go up in like this archway that's like a frame in the middle of like the city, and you look out the different sides, and then they have the past of Dubai and the present of Dubai, and then they have you go downstairs and they have this virtual reality of what Dubai is going to be like in 2050.
Wow.
Yeah, it's just it's very futuristic. I don't know if you've booked any tours yet, but
we have a lot of things.
Yeah, because we did through Viator, and we did dune bashing and something like barbecue
Camel
in the
riding.
desert.
Yeah, that's what we're doing.
Yeah, we did all that.
We're doing a boat cruise with the 4-course barbecue.
Dang.
I'm excited.
Doing the Dow River cruise?
Yes.
Yeah, we did that.
All right, I'm very jealous.
The only negative, and I swear I think it's why I've just been dragging, is we flew out on the last day of last term, and I started working on the stuff for this term as we were flying back home. So I had like no break, and it's really, I would not advise doing that for people who are heading into this class. It's like really,
yeah.
It was, I've been dragging all term.
Yeah,
because
yeah.
of it. But it was worth it. It was a
Okay,
great
I'm
trip.
still very jealous. I think my violin is very small.
Yeah.
All right,
I'm
well,
going
listen,
to be moving between terms. So if anybody
Oh,
wants to
no.
come to Tennessee, and currently because we still have floodwaters, I have lakefront property. Um, but I will gladly give you a box and
where are you moving,
Austin
Nicole?
pizza.
just about 3 miles, but we're going from 1 acre to 38, and I'm dropping about 1,000 square foot in house. So a lot of stuff's going.
Yeah, yeah, yeah. I remember you said that. Yeah. Wow, you crazy people.
I'm considering having the remodel done. You know, I don't know if I shared that we had a water leak in our house
No.
in February, and they have to tear out my entire kitchen and laundry room. And they're like, "You can stay. You won't have water for a little bit." I'm like, "I'm out."
Yeah, you know what?
I'm going to move for a week or two. You know, like
We lived through, we were renting my sister's place while they were renovating it. We were in a long story. And we lived through, I think it was only about 10 days of a kitchen rebuild. So not fun. So not fun.
I'm contemplating putting it off till summer, but I
Yeah.
really hate. I have a big hole in my wall, and you know.
Yeah, it was not fun.
Yeah.
All right,
That's
ladies.
why I'm moving between terms. We bought this house in December, and I currently have 2 mortgages because I didn't want to move till everything was remodeled and me trying to live through it.
Yeah.
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 I do have one question about since I'm continuing to track patients still and having meetings and things like that. I know that the patients that I'm tracking for Right Care, I'm going to kind of complete. Does any of my future meetings, changes, any of that impact any of this, or just leave this separate?
Leave it separate. The thing that you could do though is anyone, so Nicole, it might be you and Julie, I think are the only ones, although Whitney might be you too, is if you have people scheduled, like you have been tracking them but they are coming in 2 weeks even, which is outside your time frame. When you write your final paper, you could say that in the time frame of your 8-week project, you had this much, but ultimately now that time has gone by and you're writing your paper. So you want to be truthful. Again, always being transparent and truthful. This is what happened within the project time frame. However, we've also now captured those other people who were coming in down the road. Does that make sense?
Yes. Thank you.
Yeah. Anything else? We have half an hour, guys. I'm not in a hurry. So if you have questions, I'm happy to answer them. If you're done, I want to let you go.
Well, just an announcement. We have 100 days, 3 hours, and 28 minutes till we finish.
Oh, now Cheryl.
I wasn't the one who started the countdown. Someone else did. Yes, Julie did. And then a bunch of us on Facebook have the app.
Oh,
It's
nice.
Countdown app.
I have
Nice.
the information down
It
there.
was a goal. You know, we set goals for this project, so it was a goal for me. And then every day was a win.
Yeah.
All right. Well, I'll take it. Anything else? Oh,
Oh,
go ahead.
Our practica, you said you didn't want us to have bullets, correct? On the plan.
I would prefer that you try and write this out.
Okay.
That we're really moving in that direction. That's why I kept working on with your final summaries. We're really moving on getting you into the writing mode. I keep saying I want to be done because I don't want to hold you here, but I promise I don't have nowhere to go. So if you have questions, I'm happy to answer them.
No, I'm just going to go get a blizzard.
All right, ladies, have a wonderful night.
Thank you.
Great job,
Thank you.
all of you. Super impressed with your hard work. It was really has been a pleasure.
Okay, thank you.
Yep.
Have
We'll
fun in
talk to you
Dubai,
soon.
Whitney.
Oh, I definitely will. Thank you.
Good night, everybody.
Bye.
Bye.
Bye.